Thank you for joining us for the POLST in 2016 webinar. I'd like to introduce our Clinical Director for Consulting Services, Shirley Otis Green.
Welcome everyone. We're delighted that you could join us today. Our goal is to talk with you about POLST in 2016. Next. And we're going to begin with housekeeping. We want to remind you that this webinar is being recorded, and information on how to access the recording and the slides from this webinar will be emailed to you in the next few days. If you have questions, we invite you to post those on the chat or the Q&A box at any time. We'll be addressing those at the end of the conference. Questions will be answered following. We want to tell you a little bit about the Coalition for Compassionate Care of California. We were founded in 1998. We are a collaborative of thought leaders who represent healthcare providers, systems, consumers, and government agencies. We're all committed to improving end-of-life care, and our goal is to foster change in the areas of system, professional, and cultural readiness. Next. The Coalition is the lead agency for POLST in California. We've worked to pass AB 3000 that authorized the use of POLST throughout California and developed the POLST education curriculum. We also lead 25 local POLST coalitions and are the sponsors of SB 19, the POLST Registry legislation, and AB 637, which allows NPs and PAs to sign the form. Next. We want to remind you that the Coalition makes available many resources that you might find useful, and these are available for you to download. Next. We have an online store where you can identify and purchase many materials that might assist you in your clinical work, including decision guides and information on POLST and having advanced care planning conversations, as well as decision guides and decision tools such as GoWish. Next. We also have monthly webinar series. We are the voice of palliative care in California, and this series incubates and disseminates models and ideas to improve access to palliative care. Our goal is to work to ensure organizations and communities have the information, knowledge, and tools necessary to create the future of palliative care here in California. Next. We also want to remind you that Tuesday, December 1st, is Giving Tuesday. This is an opportunity that the Coalition invites you to join with us to raise $11,000, which will make it possible for us to have the new POLST form professionally translated into 11 languages, and will allow us to host these translations as a free download from our website. We'll be talking about this again toward the end. Next. A reminder that you can post your questions in the chat or question and answer box to the right of your screen, where all questions will be addressed at the end of the webinar. Next. Let me introduce to you today's presenters. Joanne Hatchett has worked as a family nurse practitioner in the Woodland Clinic Medical Group since 1995, caring for adult and geriatric patients in the clinic, acute care, and skilled nursing facilities. Since 2004, she has been a palliative care coordinator for Woodland Memorial Hospital and developed the Bridge program for palliative and supportive care, which serves patients throughout Yolo County. She has coordinated the Yolo POLST Coalition since 2007. Joanne has been the lead developer of the California POLST Education Program. She is a strong advocate for advanced care planning and patient and family education, and has collaborated and developed many educational tools for patients. She graduated from San Francisco State University with a BSN in 1978 and received both her MSN as a cardiopulmonary clinical nurse specialist in 1983 and a family nurse practitioner postmaster's certification in 1995 from the University of California, San Francisco. Stephen Johnson has been a member of the clinical staff of the Palo Alto Medical Foundation Internal Medicine and Geriatric Medicine departments for 34 years. Stephen was a governor's appointee of the California Healthcare Department of Consumer Affairs Physician's Assistant Committee. He is a co-author of the Geriatric Medicine chapter in the text, Physician Assistant, A Guide to Clinical Practice. And he serves on the American Academy of Physician Assistants Professional Practice Council and is currently the president of the Society of Physician Assistants Caring for the Elderly. He represents the California Academy of Physician Assistants on the Coalition for Compassionate Care of California. And Stephen is going to begin.
Shirley, thank you very much. Everybody, welcome. Today we're going to review the changes to the POLST under the new law, which allows nurse practitioners and physician assistants to sign the physician orders for life-sustaining treatment forms. The new law and the new forms will be effective on January 1st, 2016. I'm going to go over some of the basic information about POLST, some of the history for those who are new to working with the form, and Joanne will provide some suggestions on introducing and facilitating the POLST conversation in the second part of the presentation. So first, POLST stands for Physician Orders for Life-Sustaining Treatment. It is a physician order that is recognized throughout the medical system. It clearly states what level of medical treatment a patient wants towards the end of life. It is a portable document that transfers with the patient from one setting to another. It is easily distinguished by its bright pink color. It's a standardized form for the whole state, and POLST helps give seriously ill patients more control over their treatment. So why do we need a POLST? Sorry, I'm struggling with the slides here. So why a POLST? Studies have shown that patient wishes about care are often not known. Even when a patient has an advanced healthcare directive, it may not be accessible when needed. Also, advanced directives are not always clearly defined and are not a physician order for treatment. The POLST form is clear about wishes and easy to access and read. Plus, it is an actionable medical order that the healthcare providers can follow. The POLST form allows healthcare providers to know patient wishes in the event of a serious illness and to honor them. POLST is designated for people who have a chronic progressive illness, a serious health condition, or are medically frail. There are no age specifications. POLST can be used with both adult and pediatric patients. A helpful tool for determining who would benefit from POLST is the question, would you be surprised if this patient died within the next year? The question really reflects that the determination of who's appropriate for POLST is more of an art and is not a specific science. Anyone can have a POLST form if they have a reason for completing a POLST form. However, because the form should be completed based on an individual's current medical condition, it's most beneficial for those who are medically frail and have a serious health condition. So where in a person's life and advanced planning does the POLST fit in? This slide shows where POLST fits into the advanced care planning continuum. It starts at age 18 with completing an advanced healthcare directive, and then your directive should be updated periodically, names checked, contact information confirmed, and healthcare wishes reassessed. If you are diagnosed with a serious or chronic progressive illness at any age, you need to talk with your physician about completing a POLST form. The goal is that your treatment wishes are honored. Along the side of the slide in the left corner is the word conversation. This is an ongoing conversation over years with your healthcare decision maker, your family, your healthcare provider that's critically important. Joanne will talk about the conversation in more detail in a few minutes. Let's take a look at what's happening with the POLST in California. The Coalition for Compassionate Care of California is the lead agency for POLST in California and is focused on implementing POLST as a community standard of practice. The coalition works with more than 25 local POLST coalitions around the state, which have received support from the California Healthcare Foundation to promote POLST outreach and education efforts in their communities. This grassroots approach to the POLST implementation is the hallmark of the California POLST paradigm. POLST went through the legislative process as California Assembly Bill 3000. It was championed by Senator Louis Wolk of Yolo County and was supported fully by our legislators around the state. It passed unopposed and was signed by Governor Schwarzenegger in August of 2008 and became law in California effective January 1st, 2009. Some of the key points to be aware of is there is one form for the entire state. This is an important requirement for POLST to work. How many forms do we have from one skilled nursing facility or hospital to another? Not many. It is not mandatory for anyone to use the form, but honoring the form is mandatory. We must recognize the POLST form and honor the patient's wishes. We must follow the POLST wishes except if contrary to generally accepted healthcare standards or medically ineffective treatment. An example is if someone is critically ill and treatments requested on the POLST form will either not help the person or cause more harm. The doctor will discuss the appropriate plan of care with the patient and/or the family. Importantly, the POLST law protects the healthcare providers who comply in good faith with the POLST's patient's wishes. In reference, Probate Code 4782, a healthcare provider who honors a request to forego resuscitative measures is not subject to criminal prosecution, civil liability, discipline for unprofessional conduct, administrative sanction, or other sanction. For all POST revisions, the guiding principle is that the changes must provide substantial and significant improvement or clarification to the form. The Coalition for Compassionate Care of California tracks all suggested changes to the form, and the revision process is detailed and carefully followed. Changes may be prompted by new laws, as in the case this year with Assembly Bill 637. Let's review the bill and the changes to the POLST form. Assembly Bill 637 was sponsored by the California Medical Association and the Coalition for Compassionate Care of California. Assembly member Nora Campos authored the bill, which was created to increase opportunities for POLST form completion by authorized NPs and PAs to sign the POLST form. With the support of the CMA and the California Commission, as well as several other healthcare groups, AB 637 passed easily through the legislature and was signed by Governor Jerry Brown August 2015. AB 637 specifically authorizes nurse practitioners and physician assistants under the supervision of a physician and within their scope of practice to sign the POLST forms and make them actionable medical orders. Currently, POLST forms must be signed by the patient or their decision maker and a physician. AB 637 was introduced to expand access to POLST and address concerns over potential delays in obtaining a physician signature in rural areas and skilled nursing facilities where physicians may not be readily available. It's important to note that the change in the authorized signers does not go into effect until January 1st, 2016. Any POLST form signed by an NP or PA prior to January 1st will not be legally valid. The change in law provides an opportunity to increase POLST awareness and utilization and eliminate some of the potential barriers to timely completion of the form. As mentioned earlier, because the POLST form is a standardized document, the California Coalition for Compassionate Care follows a detailed process for making any changes or updates to the form. Compelled by the passage of AB 637, the POLST Task Force and POLST Documentation Committee reviewed and approved suggested changes to the POLST form to make it clear that nurse practitioners and physician assistants are authorized to sign the form. The proposed 2016 POLST form has been submitted to the California Emergency Medical Services Authority for their review, and we anticipate official approval at the EMSA Commission meeting in early December 2015. So let's go over some of the proposed changes for the 2016 POLST form. The changes are highlighted here in yellow. The 2016 POLST form includes important information in the upper left corner of the EMSA logo. Note that it says, follow these orders and contact the physician. The sentence was changed to, first follow these orders, then contact a physician, NP, PA. Below the EMSA logo is the effective date, and this has been changed to 1/1/2016, which is the date that AB 637 becomes effective. There have been no changes to Sections A, Section B, Section C of the POLST form. As before, Section A addresses the patient's treatment wishes if the patient has no pulse and is not breathing. Does the patient want CPR attempted or not? Section B addresses medical interventions if the patient has a pulse and/or is breathing. What treatments do they want during a serious illness? Each option in Section B, full treatment, selective treatment, and comfort-focused treatment, include goal statements that are very helpful in facilitating the conversation. Section C provides instructions on artificial nutrition and additional orders. The most significant change to the POLST form are in Section D, information and signatures. Instead of signature of physician, the form now asks for signature of physician, nurse practitioner, physician assistant, highlighted in yellow. The spaces for phone number, license number, and signature have also been updated to make it clear that NPs and PAs are authorized to sign the form and collect the required information. Please note that Section D also focuses on the advance directive, identifying the patient either has an advance directive or the advance directive is not available, or there is no advance directive, as well as identifying the healthcare agent named in the advance directive. In addition, AB 637 states, the healthcare provider, during the process of completing the POLST form, should inform the patient about the difference between the advanced healthcare directive and the POLST form. Asking the patient if they have an advanced healthcare directive and explaining the difference between an AD and the POLST form can be done early in the POLST conversation. Explaining that the advanced directive is a legal form naming the decision maker and encouraging the patient to complete an advanced directive is important. The POLST form defines the patient wishes during a serious illness and is a physician order. Another change to the POLST form was made in the right lower hand corner. The space that was previously referred for office use only has been enlarged, and the text has been changed to for registry use only. This change was made in anticipation of a POLST e-registry pilot, which will be likely implemented within the next year as a result of another new piece of legislation, Senate Bill 19. SB 19 establishes the POLST e-registry pilot act and requires the Emergency Medical Services Authority to coordinate with stakeholders like the coalition in the development of a pilot program to establish the framework for a POLST electronic registry. Although the POLST e-registry will likely be implemented in only 1 or 2 communities initially, this space was added to the form now to avoid having to revise the form again in the near future. Please note at the bottom of the form the sentence, form versions with effective dates of 1/1/2009 or 4/1/2011 are also valid, have been updated to read form versions with effective dates of 1/1/2009, 4/1/2011, or 10/1/2014 are also valid. The best practice is for NPs and PAs to only use the revised POLST form with the effective date of January 1st, 2016. If a PA or an NP signs an older version of a POLST form, it may not be considered valid by the local EMS or other providers. All of the information needed to make a POLST valid, the patient's name, treatment options, and required signatures, are still contained in the front of the form. The patient identifying data on the back of the POLST form, plus the name and work phone number of the healthcare provider who assisted in preparing the POLST form, under Prepare a Name. A box has been added to the middle line to allow a space for the PA or NP to write the name of a supervising physician. We want to emphasize that the supervising physician is not required to sign the POLST form if the physician assistant and/or the nurse practitioner have been authorized to sign. The layout in the middle row was adjusted to provide space for the NP and PA supervising physician's name. The checkbox for NA if POLST is completed by signing physician was deleted and replaced with preparer name if other than signing physician NP PA. On the back of the form, under Directions for Healthcare Providers, the text in the 2nd, 4th, and 6th bullets have been updated to clarify that nurse practitioners and physician assistants are legally authorized to sign the POLST form. The 1st bullet now reads, in the hospital setting, a patient will be assessed by a physician or a nurse practitioner or a physician assistant acting under the supervision of a physician who will issue appropriate orders that are consistent with the patient's preferences. The 4th bullet now reads, a legally recognized decision maker may include a court-appointed conservator or guardian, agent designated in an advance directive, orally designated surrogate, spouse, registered domestic partner, parent of a minor, closest available relative, or person whom the patient's physician NP/PA believes best knows what is in the patient's best interest and will make decisions in accordance with the patient's expressed wishes and values to the extent known. The 6th bullet now reads, to be valid, a POLST form must be signed by 1, a physician, or by a nurse practitioner or physician assistant acting under the supervision of a physician and within the scope of practice authorized by law, and the patient or decision maker. Verbal orders are accepted with follow-up signature by physician NP/PA in accordance with facility community policy. The language mirrors the legislation. The last change is made near the bottom of the POLST form under modifying and voiding POLST. The last bullet has been changed to say a legally recognized decision maker may request to modify the orders in collaboration with the physician NP/PA based on known desires of the patient or, if unknown, the patient's best interests. So in summary, the law does not go into effect until January 1st, 2016. POLST forms signed by NPs or PAs prior to January 1st. January 1st will not be valid. Only physicians, nurse practitioner, and physician assistants can sign the POLST under the new law. POLST signing authority is not expanded to include any other professional classifications. Best practice is for NPs and PAs to only use the revised POLST form with an effective date of 1/1/2016. AB 637 does not alter any other existing regulations, codes, or standardized procedures and protocols for nurse practitioners and physician assistants in California, including completion of pre-hospital DNR forms. Under AB 637, NPs and PAs are legally authorized to sign POLST forms regardless of whether the patient has chosen DNR or attempt resuscitation CPR in Section A. A new space has been added to the back of the POLST form to write the name of the supervising physician in compliance with existing regulations. The form is still valid if this information is omitted. A supervising physician is not required to countersign the form. The POLST form will continue to be called the Physician Orders for Life-Sustaining Treatment. The title will not change. For physician assistants, after a conversation with the California Physician Assistant Board, the advice is that written authorization to sign the POLST form should be added to the Delegation of Services Agreement, and terminology may include, your name, physician assistant, is authorized to discuss with patients or their designated healthcare decision maker options for serious illness and sign the POLST form. So Joanne, I think it's time for you to take over the slides here.
Very good. Thank you, Stephen. All right. For NPs, we need to include advanced care planning and POLST conversations as part of our standardized procedures or protocols. A summary of AB 637 legislation will be included on the Board of Registered Nurses website under Practice Information. The BRN contact information will be included in your PowerPoint notes, and all of your, when you get your slide presentation, the notes are very detailed. We'll take this opportunity now to discuss key elements of the POLST conversation, including POLST goal statements, patient's goals, helpful phrases, and how to build for the conversation. Introducing the conversation can be uncomfortable. It helps to begin by asking the patient about their illness and their goals. This time also builds their comfort and trust in us. Asking questions like, how do you feel things are going for you? What has the doctor told you? What do you enjoy doing every day? A patient should not be left to read and simply check the boxes. Our role is to facilitate the POLST conversation, explore goals of care, and promote informed, collaborative decision-making. It's helpful to normalize the conversation by saying, we talk about this with everyone. Some people will say, talk to me when I get sick. It helps to explain how things can happen quickly, and you may not be able to talk to us. And always, if there are questions or if you sense discomfort from either the patient or family, we need to help facilitate additional conversation with the physician, nurse practitioner, or PA. As Stephen mentioned, Section D talks about the advance directive, and we can initiate the conversation with any section, including Section D. We ask, do you have an advance directive? And if the patient says no, ask, have they thought about a decision maker? This is an opportunity to discuss the importance of the advance directive as the legal form naming the individual's decision maker. To introduce Section A, B, or C, we use medical examples into and frame each section. Patients and families can identify with these medical situations. We also place the event in the future, which helps reduce patient anxiety. Today, we'll start with Section A by saying, if someday you had a really severe heart attack, you have no pulse, you're not breathing, and you have died a natural death. We explain there is a medical procedure called CPR, cardiopulmonary resuscitation, that we can try. Unfortunately, CPR is not like what you see on TV. At this time, some people may talk to you about television, their other experiences with somebody being very ill, their thoughts. That's good conversation. It's also important that we explain risk and benefits. Patients want to know so that they can make informed choices. Using a gentle tone of voice, we explain there is a chance CPR can save someone's life, but there can be complications, fractured ribs, punctured lungs, brain damage. And CPR never cures the original problem. In some cases, it may be appropriate to explain that for an older person with multiple medical problems or difficulty caring for themselves, there is a very small chance of living through CPR. We ask, if you've died a natural death, would you want us to try CPR? The POLST form says CPR requires full treatment, and that includes the ventilator. Why? Because our emergency medical services must follow the established protocol for CPR in hopes of obtaining the best outcome. The goal statements in Section B are very helpful to read, and I actually point them out to patients as we're talking about the form. For full treatment, the primary goal of full treatment is prolonging life by all medically effective means. It's important for us to explore what is most important to the patient. What does getting better look like? So this relates back to the beginning of the conversation when we began asking them about goals. What does getting better look like? Not a slight change in lab values, but it's the ability to recover, to do important things they value. It may be, I live at the skilled facility, but I love talking to my family. It may be gardening, playing with grandchildren, or attending a future event like a graduation. And it's important to talk about trial period of full treatment. What if full treatment is not working? Some patients will say, just try CPR, but no machines. These patients want to make sure we try CPR or we try treatment, but they don't want treatment prolonged if the chances for recovery are dim and greatly burdensome. Patients need to know giving it a try includes intubation, being placed on life support. But if things aren't working, the treatments can be stopped. Some people ask about the length of trial period. Because we can't predict a future illness, we want to have the treating doctors discuss the condition with you, what is currently happening. And if you're not able to make decisions, it would be with your decision maker. And that discussion will decide on the situation and an appropriate trial period. So we can say, if you do not want to be kept on life support, if you are not getting better, we can check the box, trial period of full treatment. The diagram of medical interventions helps healthcare providers picture the relationship of CPR choices to Section B choices. You can see CPR on the left requires full treatment. With do not attempt resuscitation, the patient may choose any option in Section B. Section B describes the medical treatments a patient wants if they are very sick. And what is the patient telling us when they choose do not attempt resuscitation and full treatment? The patient does not want anyone to attempt or start CPR if they do not have a pulse, not breathing, and have died a natural death. However, if I am alive, I have a pulse, I'm breathing, I want full treatment with the primary goal of prolonging life by all medically effective means. So let's transition back to the patient who may say, I do not want resuscitation. We introduce Section B by using the example of a serious pneumonia. Pretend if someday you got really sick with a bad pneumonia and you are so sick the doctor thinks you need to have a ventilator, life support, to help you breathe, to give the medicines time to work. The ventilator is not comfortable. For people with healthy lungs and no memory problems, they usually get better in a few days. For someone with lung problems or dementia or Alzheimer's, the ability to do their normal activities, they may lose some of that ability to do what they used to do, and they may lose more memory, and they may have a long, hard recovery ahead. So we ask, would you want to be placed on the ventilator? And if the patient says yes, we check full treatment. And you can actually say the goal of full treatment, again, to confirm their choice. And it's very important to ask about the trial period of full treatment. For those who do not want to be on a ventilator, most people want evaluation and treatment in the hospital. This is selective treatment with the goal of treating medical conditions while avoiding burdensome measures. What is a burdensome measure? That is individualized for every patient, depending on their goals and their medical condition. But we consider things like complications of treatment, side effects, pain, and other symptoms, and the potential difficult recovery. The third option, comfort-focused treatment, can be introduced by saying, some people with advanced illness that we cannot cure choose to have their care focused on comfort, not going through treatments that will not cure their illness. We emphasize comfort measures are active treatments to control symptoms. We care for you, and every day we want to make sure it's the best it can be. We would only request transfer to the hospital if we could not keep you comfortable where you're living. Again, it's helpful to read the goal statement. The primary goal of comfort-focused treatment is maximizing comfort. We ask, would you want to go to the hospital for evaluation and treatment? For skilled patients who choose selective treatment, they have an extra option because the skilled facility is their home. Some people living in a skilled choose to go to the hospital for an acute illness. Others feel going back and forth to the hospital is too uncomfortable, or it no longer helps them. Skilled patients can choose to have the treatment that their facility can provide. They can stay at their facility, although they need to know what treatments the skilled can provide for them. Many of the skilled can provide IV and IV medications. The patient then can choose, do they want treatment at their skilled? And if they do, they want treatment there, they check selective treatment, and they check the box below. Request transfer to the hospital only if comfort needs cannot be met at the skilled. This means, and we need to explain this to the patient, we will treat you doing everything we possibly can here. But if you're not getting better, you're not responding to the treatments, we will transition your care to focus on your comfort so that you'll be here with us. Some people want to stay here, and they do want to die here if we cannot get them better. And so again, we confirm with them, would you want to go back to the hospital, or do you want us to treat you here? I need to make it very clear, this box is for skilled patients only, not for home, not for patients at assisted living or an RCFE. And we need to pay attention to the wording, request transfer. Request transfer is where we, the providers, the provider, the nursing assistant, and assisted living, calls EMS and is requesting transfer. We need to remember that a patient with decision-making capacity can refuse transfer from the skilled facility, assisted living, or home. We introduced Section C of the POLST with the medical example if you had a severe stroke and could not talk and could not take care of yourself. You may also have trouble swallowing. It can help to say, this is a devastating illness. You can tell the patient that difficulty swallowing can also happen with Alzheimer's or Parkinson's disease. For our POLST population who are frail and have less resilience, it is harder to recover swallowing after a severe stroke. We can say, if you have trouble swallowing, we can change the food texture and hand feed you, or another alternative is artificial nutrition with medically prescribed formula. It's important, again, for the patient and family to know artificial nutrition may not prolong life, especially with Alzheimer's or someone close to dying. It may be uncomfortable and will not prevent pneumonia. The CCCC Tube Feeding Decision Guide provides helpful information for patients and families. Some patients choose trial period, especially with head or neck cancer. We ask, would you want hand feeding to allow you to eat as best you can, or would you want artificial nutrition by tube, long-term or for a trial period? For signatures, it's important that the physician, NP, or PA never signs a POLST without first reviewing the POLST form is complete, the selections represent the patient's treatment wishes, and the treatment choices are medically appropriate given the patient's current medical condition. A POLST is always voluntary. POLST completion cannot be mandated as part of a facility admission. After a phone conversation, we document the conversation and describe to the decision maker that we've been talking to. We will mail you the POLST, or you can mail a copy because a copy is the same as an original, just as good. We're going to mail you a copy for signature, and we will send along a stamped self-addressed envelope. This important document will be mailed back because the decision maker realizes how important it is. POLST can also be faxed. It's also important to tell the patient, talking to your family is important. You give your family a gift when you talk about your wishes. Families will not feel the burdens of trying to decide, but can follow your wishes. Who can complete a POLST? Help complete. This definition from AB 3000 references are in the notes pages in your PowerPoint slides, and you will receive them after this. Remember, if there are any questions or concerns, we need to set up another meeting for the patient and their family to talk to the patient's doctor, nurse practitioner, or PA. And if I'm the nurse practitioner or PA is speaking to the family or the patient and there's still questions, we, of course, are also going to involve the patient's physician as part of this discussion. When reviewing older forms, it's recommended to update to the 2016 form and void the old form. You write void across the front of the POLST and add your name and date, and again, make sure you put that in the medical record or scan it into an electronic record, and then complete your new form. Older versions are still honored and valid. NPs and PAs should only be signing the 2016 forms. The 2016 POLST form will be available on the CCCC website in mid-December. We will all be able to order them also in mid-December. And again, we won't start till January 1st. For documentation and billing for providers, your documentation needs to include the total provider time of the visit, a description that more than 50% of the time was spent counseling, and we need to document who was included in the conversation and what was discussed. The evaluation and management codes used for the office, home, assisted living, skilled, and hospital are based on total time of the visit, which you need to make sure that you're aware of, plus the appropriate ICD-10 Advanced Care Planning Counseling Code. And again, this is in your notes. The ICD-10 code is Z like zebra, 71.89. That's Z like zebra, 71.89. We also include codes for the patient's medical conditions that we're referring to and discussing as part of our POLST conversation. And it's important to check with your practice manager regarding documentation and billing in your organization. We have additional POLST conversation tools which can accommodate different learning styles. Many of these are available online, and you can also call Kelly Creel at the Coalition, and she can help you find these forms too. FAQs are available for consumers or healthcare providers. POLST cover sheets are available for skilled facilities and assisted living and give a consumer-friendly overview of POLST. Model policies are already written and available on the CCCC website. Do not try to write your own model policy. Get one of these for acute, skilled, or hospice. They're very well referenced, and then you can modify and personalize them for your facility. I also encourage you to connect with one of the 25+ local coalitions who are working on POLST throughout California. They're great resources, and you'll probably want to get involved with them also. We have 4 decision guides, which are very helpful to enhance understanding of treatments and are written in easily understood language for patients and families. They're available in English, Spanish, Chinese, and Vietnamese. And it's time for questions.
Next slide. Thank you, guys. That was really wonderfully done. We want, as you're thinking about your questions and typing those in, we want to take this opportunity to remind everyone that the Coalition for Compassionate Care of California is participating in Giving Tuesday, and our goal is for $11,000. Our Giving Tuesday refers to the Tuesday after Thanksgiving. It's a movement to create a national day of giving at the beginning of the holiday season. Our goal is to raise $11,000, which will allow us to have the new 2016 POLST form professionally translated into 11 languages. Next slide. This will include Spanish, Chinese, Russian, Japanese, Farsi, Vietnamese, and others. The translations will be available as a free download on our website at capolst.org and will be able to mail your organization a hard copy of the full POLST form in Braille if needed. Next slide. The $11,000 will also make it possible for us to update and reprint a brochure about POLST written from the point of view of consumers. This brochure will be available as a free download from our website and available for purchase in our online store. Next. So as a reminder, if each person watching this webinar were to give just $18 a day today, we would reach our goal of $11,000. Next. We rely on donations from people like you to fund these resources that healthcare providers and consumers use every day. Please make a contribution to the Coalition this giving season. And you don't need to wait until Giving Tuesday. You can make your gift today by visiting coalitionccc.org/donate. Next. We look forward to your questions.
Thank you so much, Shirley. We have quite a few questions that have come in. Our Director of Policy and Payer Relations, Leah Morris, will be addressing your questions.
Hello. So I'm just starting to read through these questions here. I see one that says, the POLST form is to the patient, but is the physician's responsibility for obtaining the patient's informed consent and assuring the patient received appropriate information. The question, under the new law, does the responsibility for informed consent now also rest with the physician assistant or nurse practitioner, or does the responsibility for informed consent still only rest with the supervising physician? I'm going to ask Joanne or Stephen if you have any response to that question. It may be something we need to investigate a little further.
So this is Steve Johnson. Generally, I would say both physician assistants and nurse practitioners obtain informed consent in a wide variety of circumstances, for medication, for treatment, for surgery, and I think the law implies that the physician assistant and the nurse practitioner can obtain the informed consent and that the physician does not need to come back and redo the conversation. Joanne, do you have anything else?
Actually, I agree with you completely, and I think that it is implicit that as the NP or PA signs the POLST form, we are validating that we have gotten informed consent and thoroughly discussed this with the patient or the family, the decision maker. And if we had a question, as part of our responsibility, it is to either discuss with the patient's primary care doctor. Sometimes there may be discussion that we would have with our supervising physician. Sometimes it might be a specialist. But if there's questions that remain after we've gone through the form, we will either have more conversation with the physician or the physician will directly have conversation so that we close that loop.
A few more questions here. There are questions about copies of the slides as well as information. We will make those available certainly after the webinar is over. A question about how to help patients desiring a POLST document when their family members are not knowledgeable or supportive. Joanne, can you help us with that one?
Leah, could you reread the very last part of the question?
I'll just say it again. The question is how to help patients who desire a POLST document, however their family members are not knowledgeable or supportive.
Okay, thank you. What's really important, whether we know the family is knowledgeable or supportive or not, is how to bring the family into the conversation. And there's many ways you can do that. If you're having the conversation and the patient actually says, I know my family doesn't understand or doesn't agree with me, then we can talk about how the patient can have that conversation. We can set up a time where we invite the family members to come in and we talk about it as a group, and so that we can open that conversation and assist the patient in helping the family understand. And we also can provide those examples of, you know, when somebody is older, more frail, with this illness, whatever this appropriate example would be, it's understandable they can feel tired and this is what they want, or they want to try this. Whatever the issue is, we work through it with the family. I am totally a believer in family meetings. And so the other people that can help with this, you could bring in a social worker, one of the social worker designees at the skilled facility. Maybe you need a chaplain, other support members for the family. So to work through this and figure out where everybody's at, what people's goals are, and how to clarify that conversation.
I'd just like to add, if I can step in here, I completely agree with Joanne. However, I'd also say that the POLST form is for a competent patient their wishes, and I think we are obligated in many ways to record what the patient wishes are and then use the concerns about their family as a way to facilitate perhaps a better understanding between the family and the patient and the healthcare system about what their concerns are. But at the same time, I think that we really have to support what the patient wants.
And all of this goes back to, because I agree with you 100%, when we can get that support of meeting the patient's desires, hopefully we'll reduce those times that somebody either panics or because they've disagreed, that 911 is called when a patient really did not want to go back to the hospital. And
Yes.
It's through promoting conversations that we can work through that. And sometimes, you all know, it does take a lot of time.
The next question says, what language should we use when updating our standardized procedures? And it was specific for nurse practitioners.
When you get your slide set, and I did want to make sure everybody realizes when the slide set comes, which I believe may even be early next week, it's not always immediate, all of the slides have very comprehensive notes, and the verbiage is actually there where you can actually say that the nurse practitioner, you know, in the standardized procedure, having advanced care planning and POLST conversations are an integral part of my practice, and you can put more details in there if you'd like, but that's clearly specified in the notes. And then, of course, your standardized procedure would be signed off by your supervising physician. You may also want to include that the POLST form will include, you know, the name of the supervising physician. One other quick thought, and Stephen, you may want to add any other details, but the other quick thought is to make sure when you sign, when you write the supervising physician, when the person who is assisting with the POLST form, when we do our signatures, we need to make sure we write legibly on the form so other people can read it.
I would agree with that.
And a follow-up to that is the name of the supervising physician. Is that the physician listed in protocols?
Yes, it is.
Another question, for the sake of this webinar, who would be the preparer of the POLST form?
The preparer can be a trained person who knows the POLST conversation, and we actually have trained many, many people throughout California who work in the skilled facility, the nurse, the social service designee. In many facilities, nurses, social workers, chaplains have all been trained and participate in the POLST conversation. So if a social worker begins the conversation or a chaplain begins the conversation, they put their name and then where they work, their professional phone number on the back, just to designate, I have had the conversation with the patient. And then say Stephen comes into the nursing home later in the afternoon, he will then sit down with the patient, review the POLST form, and sign the POLST form, or if there needs to be changes, they might make out a different one. But Stephen would then sign the POLST form and write down and document the supervising physician. So it's whoever, the preparer is whoever initiates that conversation.
Another question says, is the POLST form now a requirement for California, or is it not mandated?
Oh.
It's a voluntary form.
Thank you.
Right,
That's
fully voluntary.
That is a key piece of information. It's always voluntary.
I'm reading the questions. Would an advance directive take legal precedence over a duly signed POLST?
The form with the most current date takes precedence. The advance directive always takes precedence in naming the decision maker. One of the important pieces that we have, though, and that's why the POLST on Section D has that section about advance directives. When you're doing an advance directive with someone, to actually identify if they have one and identify what it says, making sure that we've got their decision maker. If the patient can make their own decisions and the advance directive has different instructions for medical care than what the POLST says, then it's good to encourage and really encourage, let's do another advance directive. So your POLST and your advance directive do have the similar medical wishes expressed. But the form with the newest, most recent date takes preference, although the advance directive always is the legal form naming your decision maker.
Thank you, Joanne, and thank you, Stephen and Leah. We have no more time for questions. We'll wrap things up. I do want to let you know both of our speakers agreed to follow up with any questions that we did not have time to address here offline through email. So we will be following up with you if your question was not answered during the webinar. We do have some training coming up in February for the POLST. We'll be in San Diego.
Were
you on mute, Shirley?
Now, Leah, why don't you go ahead?
We have a 2-day POLST Train the Trainer program. We'll be in San Diego at the Sharp Healthcare on February 23rd and 24th. This is an extensive training with role play. We cover the conversation, the form itself. If you have not taken this and you're involved in the conversation and now signing the form, this may be a training that you'd like to consider. We will also have this same training in Northern California in July. So keep an eye out on our website for those dates. In addition, we can bring training to you through our consulting services. Shirley is our Clinical Director for Social Services. We can take any of our trainings and personalize them for the needs of your organization. If you have a need you think we might be able to fill, please contact us at consulting@coalitionccc.org. Our next webinar in our webinar series is coming up December 8th. It is Creating an Advanced Care Planning Continuum, a 10-year vision for California. We're going to look ahead at what advanced care planning is going to look like over the next 10 years with our own Chief Executive Officer, Judy Thomas, Aretha Davis with Advanced Health Care ACP Decisions, and Rebecca Sidori with UCSF School of Medicine. If you have renewed your membership for 2016 by that point, you can attend this webinar for free. So be sure and renew or sign up today. We have other education coming up as well. Our advanced care training in both Eureka and Sacramento, and our Building Bridges cultural training in April in Sacramento. Please check our website for dates and locations of all upcoming training. And finally, don't forget, we have our annual summit in May, and we'll be at the Fairmont, Newport Beach, May 12th and 13th. Check out our website. Early bird registration fees are active right now. And thank you so much again for being part of this. You will receive an email tomorrow with links to the webinar recording, the slide presentations, and also an evaluation form. So keep an eye out for that. If you don't receive it, give us a call. Thank you again so much, and thank you to our speakers. We appreciate your being part of this. Have a great day.